To safely manipulate intracranial pressure, we have to look past the complex neural networks of the brain. We have to treat the head as a rigid, biomechanical fluid system. When structures expand inside a fixed space, they physically displace the only yielding tissue available, the brain itself. This constraint is known as the Monroe-Kelly doctrine. It dictates that the cranial vault is a strictly closed container with a fixed total volume. That volume is divided into 3 inflexible compartments. Brain tissue occupies roughly 80%, blood takes up 12%, and cerebrospinal fluid, or CSF, accounts for the remaining 8%. Looking closely at that cerebrospinal fluid compartment, the baseline total volume in a healthy adult is approximately 150 milliliters. But that fluid is not static. The body produces roughly 450 milliliters of new CSF every single day, meaning the entire fluid volume is completely replaced 3 times over a 24-hour period. This illustration details cerebrospinal fluid flow. It's actively secreted by choroid plexuses within the lateral, third, and fourth ventricles. From there, it circulates and is translocated back into the bloodstream at the arachnoid granulations, emptying into cerebral venous sinuses. While the secretion of CSF is an active, relatively continuous process, its absorption is largely passive, relying heavily on existing pressure gradients between the subarachnoid space and the venous system. Because the skull cannot expand to accommodate excess fluid, any impedance to venous drainage or absorption quickly causes a backlog. In this closed loop, even a minor volume increase generates an immediate, compounding rise in intracranial pressure. For decades, neuroanatomy presented a distinct structural anomaly. The central nervous system does not possess a traditional lymphatic network to clear metabolic waste. Instead, the brain relies on the newly characterized glymphatic system, an alternative, macroscopic pathway that flushes proteins and metabolic byproducts from the tissue. Rather than using distinct lymphatic vessels, cerebrospinal fluid functionally enters the periarterial space, a defined gap bounded by blood vessels and the surrounding brain tissue. This exchange is facilitated at the cellular level by astrocyte end feet. These specialized glial structures contain aquaporin channels that actively regulate the movement of water. Driven by convection bulk flow, the fluid washes directly through the brain parenchyma, sweeping metabolic waste products into the perivenous space for ultimate drainage. This clearance mechanism is highly state-dependent. During sleep, the periarterial space physically expands, significantly increasing the volume and speed of waste removal. This introduces a critical pharmacological variable. Volatile anesthetics severely restrict this glymphatic transport, whereas intravenous agents like dexmedetomidine preserve the expansion of the periarterial space and maintain waste clearance. Choosing an anesthetic agent means actively modifying the brain's physical capacity to clean itself. This mechanism explains why specific drug choices correlate directly with differing rates of post-operative neurocognitive dysfunction. Moving past the fluid compartments, we must address the most dynamic element of the intracranial space, the vascular compartment, which accounts for roughly 12% of the vault's total volume. It is vital to strictly separate 2 distinct physiological concepts here: cerebral blood flow, or CBF, which dictates how quickly oxygen and substrates are delivered to meet metabolic demand, and cerebral blood volume, or CBV, which is the actual physical space that blood occupies inside the skull at any given moment. The overarching clinical absolute is that intracranial pressure is determined by changes in physical volume, not the velocity of the flow. This distinction exists because the cerebral venous system acts as a highly compliant hemodynamic buffer, stretching or compressing to accommodate shifts in arterial delivery. Because of this venous buffering, when arterial velocity surges, the total vascular bed does not expand at a 1-to-1 ratio. A massive 50% increase in cerebral blood flow yields a much more modest 20% increase in total cerebral blood volume. To actively manipulate that volume, the anesthesiologist relies on cerebral vascular carbon dioxide reactivity, which is the fastest and most direct clinical lever available. The normal physiological response is incredibly precise. Cerebral blood volume fluctuates by roughly 0.049 milliliters per 100 grams of brain tissue for every 1 millimeter of mercury shift in arterial CO2 tension. Scaled up to an average brain, allowing PaCO2 to rise from 25 to 55, physically expands the total cerebral blood volume by approximately 20 milliliters. Inside a rigid skull, where compliance is already compromised by a tumor or hemorrhage, actively venting off that CO2 to shrink the vascular bed by 20 milliliters is often the difference between maintaining a safe surgical field and precipitating a lethal brain herniation. The second major mechanism governing the vascular compartment is cerebral autoregulation, the brain's intrinsic ability to maintain steady tissue perfusion despite wide fluctuations in systemic blood pressure. Under normal conditions, as mean arterial pressure increases, cerebral arterioles reflexively constrict to prevent hyperperfusion. This creates a counterintuitive reality. Driving up systemic blood pressure reduces total cerebral blood volume as vessels narrow to maintain flow. But in an injured brain, autoregulation is abolished. Vessels become passive conduits. Any pressure increase forces a linear volume spike. This flowchart illustrates the cascading pathophysiology of intracranial hypertension, mapping how a mass lesion forces compensatory shifts in fluid volume. Notice the elements marked with asterisks. Variables like airway pressure, PaCO2, and systemic blood pressure are direct nodes of control to break the hypertension cycle. A severe spike in intracranial pressure is rarely isolated to a single expanding mass. It represents the compounding systemic failure of the brain's interconnected venous, fluid, and autoregulatory volume buffers. With the physical constraints defined, intravenous anesthetics act as precise tools for pharmacological engineering of the intracranial space. The defining characteristic of most intravenous agents is that they strictly preserve neurovascular coupling. These drugs do not act as direct vasoconstrictors. Instead, they depress the cerebral metabolic rate, or CMR. By lowering the brain's demand for oxygen, the local vasculature automatically downregulates blood flow to match that reduced need. Barbiturates, such as thiopental, execute this perfectly. They produce a globally uniform, dose-dependent decrease in both metabolism and flow across the entire brain. However, they hit a hard physiological floor. The maximum reduction in metabolic rate caps at nearly 50%, which corresponds to the point where the EEG becomes completely isoelectric. Pushing higher doses past this flatline yields zero additional hemodynamic benefit. Furthermore, patients quickly develop acute tolerance to barbiturates, limiting their long-term efficacy for sustained coma dosing in the neurocritical care unit. This is why propofol is the preferred neuroanesthetic. It mirrors the reliable, coupled suppression of barbiturates, but adds the unique benefit of actively decreasing regional cerebral blood volume without the same rapid tolerance profile. But there is a dangerous pharmacological trap here. If a patient is already heavily loaded with propofol, their metabolic demand is maximally suppressed. Introducing volatile anesthetic gas at this stage bypasses metabolism entirely, acting purely as a direct vasodilator and triggering a sudden spike in intracranial pressure. Moving beyond propofol, we encounter agents with highly specific regional profiles, or secondary hemodynamic traps that require careful navigation. Etomidate technically preserves flow-metabolism coupling, but its effect is not uniform. The suppression of metabolic demand is patchy, forebrain predominant, and leaves other regions highly active. Etomidate also carries a strict efficacy limitation. It only lowers ICP if the patient's baseline EEG is still highly active. If the cortex is already deeply suppressed, etomidate provides no further intracranial volume control. Due to exacerbating focal ischemia and inducing severe adrenocortical suppression, its use as a continuous infusion in neurocritical care has been largely abandoned. Opioids, by contrast, offer a relatively stable baseline, providing only modest, coupled reductions in cerebral metabolism and flow. With high-dose opioids, a secondary systemic reflex triggers a precipitous drop in mean arterial pressure, dragging down cerebral perfusion pressure. Arterioles detect this drop and immediately dilate to maintain blood flow. By opening up, they expand their volume, unintentionally spiking intracranial pressure. Finally, there is the absolute pharmacological outlier, ketamine. Through specific NMDA receptor antagonism and selective limbic system activation, ketamine actively increases both the cerebral metabolic rate and total cerebral blood flow, breaking the standard pattern of intravenous suppression. For decades, this physiological profile branded ketamine as strictly contraindicated in neurotrauma. Modern evidence overturns this. If the patient is adequately sedated with a baseline agent and carefully ventilated, ketamine does not trigger dangerous ICP spikes. In fact, its NMDA blockade actively protects injured neurons from lethal glutamate excitotoxicity. Safe neuroanesthesia hinges on the precise management of the cranial vault's rigid physical constraints. This process requires balancing 3 distinct levers: fluid turnover through the glymphatic system, blood volume expansion via PCO2, and metabolic suppression from intravenous agents. Every clinical decision serves as a real-time adjustment to the brain's internal environment, engineering intracranial compliance with every breath and every bolus.